Swapnil, you will be presenting. स्वप्निल प्रेजेंट कर रही है, मोनम और पूजा। स्वप्निल, पूजा, आर यू देयर?
Pooja, Pooja, have you signed in? Pooja, Monam.
Hello, ma'am.
पूजा,
Yes, ma'am.
हाँ, अपना शेयर करके चेक कर लो, शेयर कर पा रहे हो कि नहीं।
Ma'am, is the screen visible?
स्क्रीन इज नॉट विजिबल। शेयर कर रहे हो?
पूजा, शेयर स्क्रीन करके देखो बेटा।
हम शेयर कर रहे हैं मैम।
नहीं, इट्स नॉट विजिबल।
इसमें हिस्टोलॉजी एंड ग्रेडिंग ऑफ द ह्यूमन को करते हैं।
एक बंद कर दो।
तुमने अपनी आईडी से ये स्लाइड शेयर नहीं हो रहा है। हेलो सुषमा, हाँ यस मैम। मैम शेयर, जी जी मैम। हाँ हाँ मैम, बुला रहे मैम उनको।
Wisdom.
ये ऑप्शन कहाँ आ रहा है कुछ?
उनसे पूछना कि उनका क्या डे चल रहा है।
या तो बोलिए वो अगला सुन रहे हैं।
Hello, ma'am. Are we audible, ma'am?
Pooja, have you joined? Pooja, Monam.
Yes, ma'am.
Yes, ma'am.
Okay, your slides were visible now, I think.
Yes, ma'am.
Connection is okay.
Okay.
Okay, good. Are you prepared well?
Yes, ma'am. इसको बंद कर दीजिए। सेव नहीं हो रहा है। नहीं, अभी तो बंद करना है ना मैम। अब क्यों कर रही हैं? ये बंद कर। तो स्लाइड से नहीं हो रहा है। अभी नहीं हो रहा है। नहीं चलिए ठीक है।
नहीं दवा ले लो। उसका सरनेम
मेरा क्या हो रहा है ये?
अच्छा अभी तब तक हमें तब तक रुकना है। तो पहले आप अपना बोलेंगे और फिर हमारा आएगा, है ना?
तुम भी जब बोलेंगे तो वो फिर पूजा जाती है।
अच्छा तब वो छोटी नाम का है। ये बोल के देखिए कुछ नहीं।
किसने इन्फॉर्म किया? अरे मैं कब करूँगी? मैं तो ग्रुप में बैठी हूँ, तुम कैसे तुम्हारे से बात करती हूँ? मैंने बोला था वहाँ के साथ को करो, खुद से देख लो। हाँ तो जो करना है तुम्हें inform करो। कल किसने देखा था?
फ्री फ्लोटिंग ना।
तो कल उसको नहीं लगा था। अभी कितनी ब्लीडिंग हुई देख के जाना। और अभी कल कंसेंट फोटोला क्या था और आज कंसेंट फोटोला क्या? कल क्या हुई थी कंसेंट फोटोला? पता नहीं। ठीक।
ऐसे होता है सेशन। अच्छा record to be not engaged to begin. नहीं वो कौन सी पॉलिक होती है ना। हाँ पॉलिक
क्या था?
आप ये बता दीजिए इसमें क्या लिखा है। हैव नॉट इंग्लिश में
न्यूट्रल तो लैटरल ग्रिप होता है। इसमें एंगेजमेंट कैसे पता चलेगी तुम्हें?
एक फंडल होती है जो मेरे बता दीजिए प्लीज, नहीं पढ़ पाए। लैटरल है और एक लेफ्ट साइड राइट होती है, एक लेफ्ट होती है।
इसमें ग्रिप लिखना होता है कि पर फाइडिंग लिखोगे ना।
हाँ वही वो लिखनी होती है। फंडल लिख दी, लैटरल लिख दी, लेफ्ट साइड में होती है, राइट साइड में लिख दी।
और फंडल ग्रिप में तुम्हें ये थोड़े ब्रीच थी है।
हाँ नहीं तो सिफेलिक है ना, तो फंडल हमें ऊपर
अच्छा हाँ ब्रीच मिला। फिर लैटरल ग्रिप किया।
एक तरफ बैक में
Vijeta, mute yourself.
यस मैम।
12 का है ना, 2 खाना और बन जाए तो बस अच्छा है। बस हो गया।
Vijeta, start.
So we start. Okay, ma'am. Very good afternoon to all the respected teachers, colleagues, and dear juniors. I welcome you all. As we all know, Golf as an academic platform has been an important source of knowledge and active learning to all the PG students. In this continuous efforts of learning and teaching postgraduates, Department of Obst and Gynae KGMC is ready for the next session of golf with very common obstetric condition, gestational diabetes. Before starting the session, I would like to invite golf coordinator, Dr. Anju Agarwal, ma'am. Ma'am is professor in the Department of Obst and Gynae, KGMC, Lucknow. I welcome you, ma'am.
Thank you, Vijeta. And a very warm welcome to all our participants and all the PGs. As you all know, 14 November is the World Diabetes Day. And that is why we planned this topic of gestational diabetes mellitus for today, because it is one of the important topics for your examination. And we are very happy to have Smriti with us, who was also instrumental in being part of the team which framed the GDM guidelines for the Ministry of Health, Government of India. And we'll have a very interactive case discussion. So a very warm welcome to all. And I request Head of the Department, Dr. Jeswar, to please give her blessings to the program.
Good afternoon. Hello.
Yes, ma'am.
Ma'am, audible hai aap?
Hello. I think there is a echoing of the. Hello. Good afternoon to all of you. Okay. Now audible or not?
Ma'am, you are audible, ma'am.
Hello. Good afternoon to all of you. Hello, Anju. I am audible. Hello.
Yes, you are audible.
Okay. Good morning, Hemji. Good morning. I can hear you. Good. So good afternoon to all. This is my proud privilege. And as we have a very good topic that is on the diabetes, gestational diabetes, which is a very common problem in pregnant women. And I happy to see that so many people have already joined on this platform. And I congratulate Dr. Anju as well as Smriti for creating this platform to enlighten our PG students. And welcome to all of you, and especially our faculties from the different places and our residents. Dear Anju, please continue the program.
Thank you, ma'am. Thank you
Thank
so
you,
much,
ma'am.
ma'am, for your kind words. Today we are privileged to have an excellent teacher and our beloved Dr. Smriti Agarwal, ma'am. Ma'am is professor and head of Department of Obst and Gynae, RML Lucknow. Ma'am, ma'am will be speaking up upon management and monitoring of gestational diabetes. Ma'am, hello. Smriti ma'am, are you there, ma'am?
Yes, ma'am was there. Actually, there was some glitch in connection. So we are just waiting for 2 minutes. I am just calling ma'am.
Yes, yeah, I'm here. Thank you so much. Jeta, can you?
Ah, so Spriti is here. So we share the slides, Spriti.
Ma'am,
I think there's
Mona,
a
Ma'am, actually, from my side, it is saying that I cannot share the slides. We are just sorting out. Within
okay,
2-3
I
minutes,
will
we are
share.
sorting out,
I
ma'am.
can share.
मोना ले लो फिर अपनी तरफ से कर दो ना.
जी मैम, वो हमारे से मैम हो नहीं
I
पा रहा है
think
मैम.
it
अच्छा,
would be
अंजू के
great
पास
if
है?
Mona can share my slides.
मैम वो
Okay.
Anju is
Are
doing.
the slides visible?
यस मैम.
Okay, let me just.
आ गई है, बस full screen कर लो. Do it full screen.
Hi, is it visible as full screen?
Yeah. It's okay. Smriti is there.
Spriti, can you see? I'll just call her, ma'am. She was having some problem in her connection.
देख लो, नहीं तो फिर तो anyone else can continue this.
वो मैंने इसीलिए अपने से कर दिया है.
So in the meantime, good afternoon, everybody. I had
Welcome, Uma ji.
Yeah.
Welcome, Uma ji.
Yes, thank you so much. I was relatively free today, so I again get
Actually,
the
I
old.
don't know why the problem with Smriti.
So
Anju,
nice to have you, ma'am, here. And Dr.
Definitely.
H.P. Gupta, ma'am, also. Welcome, ma'am.
Okay. Happy to see Uma also.
I am also happy to see Uma ji. चलो.
So,
क्या करें, स्मृति सोच रहा फोन करो, देखो क्या प्रॉब्लम आ रही है, नहीं तो फिर.
हाँ.
can you hear me? If you can.
हाँ, I can
Yes,
hear
now
you.
we can hear you. Join with your phone, Spriti.
अभी वो म्यूट हो गई है.
हाँ. Spriti, phone से join कर
I
लो.
am on my phone. Can you hear?
Yeah, we can hear you.
Thank you. Yes, you can hear me, ma'am.
सुनाई दे रहा है. सुनाई दे रहा है.
All right. So a very big thank you to Professor S.P. Jaiswal ma'am and Anju ma'am for connecting.
स्मृति प्रॉब्लम आ रही है, उससे मोबाइल से बोल लो ना स्मृति. स्लाइड तो ये अंजू कंटिन्यू कर लेगी, और नहीं तो फिर अंजू फिर तुम ले लो, एक और कर लो. नहीं, प्रॉब्लम आ रही है उधर से.
So maybe we can take up the case first and then take up this.
That is also okay. Case अगर if the girls are prepared, they are ready.
हाँ,
वो
girls
start
are
करो.
prepared. They are ready.
हाँ, तो वो ले लो फिर जब तक.
And Dr. Amita is there. Amita, you are there now? Amita Yadav.
Yes, ma'am. Yes,
Ah,
ma'am.
so can we take up the case first?
Yes, ma'am.
Right.
For case discussion,
Okay.
today we are lucky to have a panel of experts. Dr. Anju Agarwal, ma'am. Ma'am is professor in the Department of Obst and Gynae, KGMC. And Professor Dr. Smriti Agarwal, ma'am. Ma'am is professor and head of the department in RML Lucknow. And Dr. Amita Yadav, ma'am. Ma'am is associate professor and head of the department in RDMS Lucknow. RDMS Banda. Sorry. I welcome you all, ma'am, for case presentation. Today case will be presented by Dr. Pooja Jayatri and Dr. Monam Jayatri from KGMC Lucknow. Over to Pooja Jayatri and Monam Jayatri.
Good afternoon to all respected teachers. I am Monam Jayatri, presenting case on gestational diabetes mellitus. Patient name is Mrs. Zareen Zafri, age 25 years, wife of Mohammad Aoun, resident of Sadhganj, Lucknow. Patient admitted on 5th of November with chief complaint of amenorrhea for 9 months with moderate anemia. Menstrual history. Amenarche was at 15 years of age. Cycles were regular of 28 to 30 days, with duration of 3 to 4 days. Flow was average and dysmenorrhea was absent. Her LMP was 4 March 2022 and expected date of delivery is 11 December 2022. Period of gestation on date of examination 35 week 2 days. Objective history. Gravida 3 para 2 plus 0 live 2 married life of 8 years. Para 1 7 years female full term vaginal delivery at 9 months alive and healthy at QMH with spontaneous progression of labor, no history of gestation diabetes mellitus in this pregnancy. Para 2 6 years back female full term vaginal delivery which is alive and healthy at QMH. It was also spontaneous progress of labor with history of hypothyroidism in this pregnancy and no history of gestational diabetes mellitus. No
So just a minute, Monam. Would you like to tell, besides no history of GDM in these pregnancies, what was the birth weight of the babies?
Ma'am, in first pregnancy, the birth weight of baby was 3.5 kg. And in second pregnancy, the birth weight of baby was 3.2 kg.
So if you have asked, it should be mentioned in your presentation. That is important. And also whether there was any postnatal complication in the baby or not. Because sometimes even women who are not GDM and the baby is good birth weight, they may develop hypoglycemia later in the postnatal period. All right?
Yes, ma'am.
Can you hear me?
No history of
Monam? Yeah.
No history of ovulation induction, IUI and IVF in this pregnancy and spontaneous conception. No history of arterial infection, wound infection, resuturing, and blood transfusion. Present pregnancy. Patient was booked at QMH at 7 weeks of gestational age. History of present pregnancy. First trimester. Patient had UPT positive at 15 days of overdue. First ANC visit was at 7 weeks, 6 days of period of gestation. Folic acid supplementation was given and ANC investigations advised. DIPSI at 8 weeks of gestation was 144 milligram per deciliter and serum TSH was 4.29 milligram per deciliter. No history of any drug intake, radiation exposure, excessive nausea and vomiting, bleeding per vagina. There was no history of burning micturition, increased frequency of micturition, and no history of any drug intake. Patient was diagnosed with severe anemia in first trimester, hemoglobin 6 gram per deciliter. Iron profile was advised and suggestive of iron deficiency anemia. And HPLC was normal. Thalassemia profile was normal. Patient was advised admission but refused. Deworming done. Iron, calcium, and multivitamin tablets advised. Patient was advised on medical nutrition therapy for 2 weeks and then asked to come with reports of blood sugar, fasting, and postprandial.
I have a question, Mona. Deworming is advisable in first trimester?
Sorry, ma'am?
Deworming to the patient is advisable in the first trimester of the of pregnancy?
Do you normally do deworming in the first trimester?
First trimester.
No, ma'am.
When is the recommendation for doing deworming?
Second and third trimester. Ma'am. Third trimester.
है ना? So it is recommended to be given at 14 weeks of gestation.
After 14 weeks of gestation.
So what is the category of the drug? Then come to the drug.
Which category drug is your albendazole? You are giving albendazole for that, no? In pregnancy, you are giving albendazole. Which category drug it is?
So that is an important question. Whenever you are giving any drug in the first trimester, you must know the safety and the category of that drug in the first trimester. As such, iron can also be given in the first trimester, but usually it is not given because it leads to a lot of nausea and vomiting. As such, iron does not lead to any otherwise adverse effects. And deworming routinely is advised at 14 weeks or beyond. In the first trimester, if you have a strong suspicion of worm infestation, that's something different, but only due to anemia, deworming should not be given. You should wait till 14 weeks. All right. Though albendazole is considered to be a category C drug, and that is why it is not recommended in the first trimester.
Yes, ma'am. In second trimester, Tedwig was covered at 4th and 5th month of gestation. Quickening felt around 5th month of pregnancy. A scan for fetal well-being was done at 5th month and which was reported normal. No history of pedal edema, blurring of vision, headache or any epigastric pain or decreased urine output. No history of bleeding per vaginum or leaking per vaginum, and no history of increased micturition or burning micturition. Third trimester, no history of excessive nausea and vomiting, pain in abdomen, bleeding per vaginum or leaking per vaginum, no epigastric pain, headache, blurring of vision or pedal edema, no history of dyspnea or palpitation, no history of decreased fetal movement, and no history of polydipsia, polyuria and burning micturition. Patient came to ANC OPD on 5th November at period of gestation of 34 weeks, 6 days and admitted for safe confinement. Blood sugar monitoring was done and DEXA coverage was done.
Why blood sugar monitoring? You were saying कि third trimester was uneventful. It was going uneventful, na bache?
Yes, ma'am.
So why you have admitted the patient for blood sugar monitoring? It means there was something you found and you have asked the patient to admit and for blood sugar monitoring.
Now, when the patient came to OPD, she had brought a report of hemoglobin 7.4 in the third trimester. And she is also a known case of GDM. So she was admitted for workup. Here we got a hemoglobin report of 9.4. So only DEXA coverage was done along with blood sugar monitoring.
But why DEXA coverage? Were you planning to deliver her at that time? When is DEXA coverage recommended?
It is recommended when we are planning to deliver the baby preterm.
And we expect the delivery to occur within a week of giving dexamethasone. It is not a long time coverage कि हमें अगर 2 महीने बाद deliver करना है तो हम उसे DEXA coverage आज कर देंगे. So what was the indication of doing the DEXA coverage here? So that is an important message which our residents must take, that unnecessary DEXA coverage should not be done in any patient.
Otherwise there is other complications are there.
Yes. So
And you are
ऐसा
planning-
नहीं है कि any patient who's admitted to the hospital, you have to do DEXA coverage. All right. Only if you are planning to deliver that patient within a week, or you're expecting her to deliver spontaneously within a week, then you need to give DEXA coverage. And that too before 34 weeks of gestation. हाँ बताओ, आगे बताओ.
Table shows the sequence of events that happened during the ANC visits. She had her first visit at 7 weeks of gestation with complaints of amenorrhea and UPT positive at home. She was advised ANC investigations at 8 weeks of gestation. She had come to us with an hemoglobin report of 6. She was advised admission, but she refused. At 10 weeks of gestation, the patient came to QMH with complaints of itching. At this gestation, ma'am, she had also brought her serum TSH report, and she was started TAP thyronorm, 25 microgram. Iron and calcium and multivitamins were started in view of severe anemia, as she had refused admission, and a dermatology opinion was taken. At 13 weeks of gestation, she had come for a routine visit when she...
1 minute, Pooja. Again, there's a discrepancy. At 10 weeks, okay, we understand you started iron due to the anemia, but why did you start calcium? Calcium again is recommended to be started only after the first trimester. है ना, तो ये ऐसा नहीं है कि रूटीन में हमने आयरन लिखा है तो कैल्शियम भी लिखना ही है. आयरन इंडिकेटेड है इसलिए लिखा है, कैल्शियम नहीं लिखने की जरूरत है उस समय.
Yes, ma'am. At 13 weeks, ma'am, when patient came to us, we had advised her TIFA in view because she was a GDM case and it was diagnosed before 18 weeks. So we planned the patient for TIFA.
At 5 days may you are advise the patient for TIFA. What other you are planning for? What do you want to see in your that USG?
Ma'am, in case of GDM, however, the risk of just congenital anomalies low because of late onset of the disease. But in this case, since we had diagnosed it at the first visit, we had planned the patient for TIFA. We want to look for the liquor and other congenital anomalies, most commonly congenital heart diseases in the fetus.
In 13 weeks, 5
And
days.
what gestation?
In 13 weeks, 5 days heart anomaly. Are you completely ruled out with that?
Ma'am, we have planned the patient for TIFA. TIFA will be done at 18 to 20 weeks only.
So in 13 weeks, 5 days, what do you want to do?
Ma'am, we do NT-NB scan and double marker test, but since double marker is
You
not...
should mention first before that, bache. You have to mention NT-NB, then plan for TIFA.
Yes, ma'am.
And what does examination? How can you calculate that dose of antithyroid drugs? What is the what was the weight of the patient?
Ma'am, pre-pregnancy 56 body weight was there.
Then how can you calculate that dose for antithyroid drug? What is the formula, beta?
0.2 microgram per kg body weight.
0.2 microgram और pre-pregnancy weight कितना था patient का?
Ma'am, 56.
56. तो तुम्हारी dose कितनी आई?
$11.2.
Hmm. 25.
तो 11.2 के नियरेस्ट कितनी टेबलेट आती है?
आती है ना, इससे कम कोर्स की 25 से कम की आती है।
12.5 की आती है मैम टैबलेट।
हाँ, तो आपने डबल डोज मतलब कुछ सोच के ही दिया होगा ना। सब देते हैं तो हम भी देते हैं। चलो आगे
Though national guidelines, they have said that in subclinical hypothyroidism, they have advised 25. As long as your serum TSH is less than 10.
At 26 weeks, ma'am, when patient came, she was advised to get a blood sugar fasting PP done, as she was advised blood sugar. She was advised medical nutritional therapy earlier, and after 2 weeks, she was advised to get a blood sugar fasting PP and HbA1c done, which was normal. At 27
नहीं,
weeks,
जब ब्लड शुगर फास्टिंग पीपी बोलते हैं तो पेशेंट को क्या कहते हैं, किस समय कराएगी फास्टिंग और कब कराएगी पीपी?
ma'am, fasting sample is given after an overnight's fasting period in the morning, and PP is given after a full meal and the afternoon, 2 hours after the full meal in afternoon.
तो पूरी बात लिखनी होती है कि 2 hours after lunch, है ना? It should not be 1 hour or 1.5 hours. कोई, क्योंकि अदरवाइज पैथोलॉजी पे आप छोड़ देंगे तो कोई 1 घंटे में निकालेगा, कोई 1.5 घंटे में, कोई 2.5 घंटे में.
Yes, ma'am.
So you have to tell the patient 2 hours after lunch.
At 27 weeks of gestation, when patient came, she was advised for USG Obst for fetal well-being, and 24-hour urinary protein was done. At 33 weeks of gestation, when she came, she was advised, since she was a case of severe anemia earlier and what was put on medical management, she was advised to get a repeat hemoglobin done. At 34 weeks of gestation, when we had taken the case, she was advised admission in view of hemoglobin 7.4 in the 3rd trimester. Past history, there is history of hypothyroidism in the 2nd pregnancy of the patient also. There is no history of suggestive of hypertension, diabetes, heart disease, tuberculosis, asthma, epilepsy, jaundice, liver or gallbladder disease, or any chronic illness or previous surgery. Personal history, patient is a vegetarian and currently patient is taking 2200 calories. In the morning, this is the diet chart that we had given her now. In the morning, she takes tea without sugar with 2 biscuits.
Can you show us your calorie calculation for this patient?
Good morning, ma'am. Ma'am, can you hear me now?
Yeah, now you are clear.
Oh, God.
Hi.
So come and join the case discussion and then we'll have your talk.
Yes, ma'am. Thank you.
Can you show us a calorie calculation for this?
Yes, ma'am. Ma'am, the total calorie required according to MOHFW is basal metabolic rate multiplied by physical activity level. And basal metabolic rate, since she is a female of 35 years old female, the formula is 8.3 into body weight plus 788 multiplied by physical activity level. Since she is a sedentary, she is having a sedentary lifestyle, the physical activity level is 1.53. This was calculated and it came out 1916, and since she is in 3rd trimester, we have added 350 calories, which came out to be 2266.
Okay. So, ma'am, can I add something?
Yeah, definitely.
So, Pooja, like what you have said, written as, it is a brief outline. So, how did you ask her all these things which she eats? What is that method called? This is a very ideal diet chart which you have just shown us. Is she actually taking this diet chart?
Ma'am, we have started this diet chart. Earlier, she was not taking. Earlier, she was taking only 3 meals, 3 heavy meals during the day.
So when you talk about history, no, you also talk about what she was taking. And then maybe you can add on that over the last few days, since she's admitted or since she's under your supervision, then you have advised her this diet chart.
Yes, ma'am.
This is called a 24-hour recall method, where you want to ask the patient what all she has taken over the last 24 hours, right?
है ना, और हिस्ट्री में वही आएगा जो वो ले रही है, फिर तुमने क्या एडवाइस किया वो तो मैनेजमेंट में आ जाएगा.
Yes, ma'am.
Okay, आगे चलो.
The patient is taking adequate sleep, normal bowel bladder habits, no history of smoking, tobacco chewing, alcohol intake, or other substance abuse. The patient was instructed to walk for 30 minutes after breakfast, lunch, and dinner, and she is doing that since first trimester. Family history, there is no other significant family history. Social history, the patient is a graduate and housewife. The husband is also graduate and doing private job, earning 30,000 per month. He belongs to an upper middle class family as per modified Kupuswamy scale. Contraceptive history, the patient has got copper T375 inserted after her second pregnancy, followed by use of OCPs on and off.
Pooja, you said no other significant family history. What do you mean by that? What family history did you ask and what no other? कोई बताइए तुमने positive.
किसी फर्स्ट डिग्री रिलेटिव में डायबिटीज की
All
हिस्ट्री
right.
करेंगे.
और
What all family history do you take if a woman is diabetic?
First of all, we ask about the history of diabetic parents and diabetic parents and diabetic siblings in the first degree relatives में अगर diabetic है या वो gestational diabetes उनको रहा है पहले तो. And then we take
No family history of? What are the other family history which you ask generally in an antenatal woman?
Ma'am, we ask about the history of any other congenital anomalies in the family. We ask about the other hereditary disorders running in the family. If other members of the family are suffering from any known hereditary disorders or any history of any other history.
Okay, I think ma'am we'll catch her later when she presents the case further.
चलो ठीक है.
आगे चलो.
General examination, patient was lying comfortably on couch at the time of examination and she is well oriented to time, place and person. Weight, pre-pregnancy body weight was 56 kgs and present weight is 68 kgs. Pre-pregnancy BMI was 21.8 kg per meter square. Pulse rate 94, regular, normal volume.
What is the weight gain?
12 kgs.
So, okay. So when you say about the BMI, you should immediately say at that time which category she comes under.
Ma'am, this is a normal BMI for Indian standards.
Yes. Okay.
Pulse rate 94 beats per minute, normal volumic, regular, no radial, radiofemoral delay, respiratory rate 18 per minute, thoracoabdominal. BP 118/74 mm of Hg in right arm and sitting position. Temperature is 98.7 degrees Fahrenheit. There is no pallor, no icterus, cyanosis or clubbing, no thyromegaly, no lymphadenopathy. Bilateral breasts are soft. Respiratory system, bilateral vesicular sounds heard, no added sound heard. Cardiovascular, S1, S2 heard normally, no added sounds heard. CNS, the patient is well oriented to time, place and person. Obstetric examination. Inspection, abdomen is distended in shape, umbilicus flat, linear nigra and stria gravidarum are seen. All hernial sites are intact. There are no dilated veins, no visible pulsations, peristalsis seen over the abdomen. Palpation.
So when you say abdomen is distended, you don't say distended in shape. You say abdomen is uniformly distended or distended in the lower abdomen, and then shape is ovoid, longitudinal ovoid. Okay.
Yes, ma'am.
Okay, then.
Palpation was done after bleeding evacuation and correcting dextrorotation. The symphysis fundal height was 36 centimeter, abdominal girth was 38 inches. Fundal height is term size. On performing the obstetric maneuvers, fundal grip, broad, soft, non-ballotable mass suggestive of the podalic and lateral grips. On the right side, a smooth curve was felt suggestive of the back of the baby. On the left side, multiple knob-like structures were felt suggestive of limbs. Pelvic group 2, a hard globular but ballotable mass was felt suggestive of head. Pelvic group 1, the head was not engaged at the time of examination. The uterus is relaxed, Liker is average.
So even when you talk about the grips, no, Pooja? So again, you should not say pelvic grip 2 first. That is Leopold 2. Okay, so you say pelvic grip 1, where you feel what is actually occupying the lower uterine segment. And pelvic grip 2 is whether you want to see whether the head is engaged or not.
Yes, ma'am.
Okay.
And just mention the Leopold maneuvers. Don't mention the pelvic grip.
Yes, ma'am. On auscultation.
At the same time, when you are talking about the symphysiofundal height, go back to the previous slide. You must, because this is a patient of diabetes more so, you must say what is your clinical weight estimation. Right, where you have measured the symphysiofundal height, you have measured the abdominal girth, you have also measured everything, the fundal height, right? At the same time, how you are clinically estimating whether the Liker is average or not. Same way, you must say what is the clinical estimation of fetal weight in a range, okay? Whether it is around 3.5 to 3.6 kg, 3 to 3.2 kg, like that.
Yes, ma'am.
Okay.
On auscultation, the fetal heart sound was heard on the left umbilicospinal line. The fetal heart was 140 beats per minute regular. On PS, there was no discharge. The os was closed. Cervix and vagina.
Speculum examination, Pooja.
Yes, ma'am.
Os closed. You have mentioned in your heading per speculum examination. It is a per vaginal or bimanual finding, na? Why you have mentioned os closed in your per speculum examination finding? It is a per speculum examination finding.
No, ma'am, it is a PV finding.
And other thing?
So how can you make out that the os is closed on per speculum? Can you make out? You can have a rough idea whether the os is closed or open, but you can't say categorically that. And what all do you see on per speculum when you do in a 1980 woman? You look for any discharge, you look for any leaking, you look for any bleeding.
Yes,
you want to see whether the cervix is healthy or not, isn't it?
Yes,
so all those things are missing here.
Yes,
okay, so you must write that the cervix appears healthy, there is no bleeding, there is no leaking, there is no discharge, and the os appears to be closed. But you can categorically say whether the os is closed or not only on PV examination.
Yes, ma'am.
Now this patient is 36 weeks pregnancy. So would you like to do a PV examination if she is not in labor?
No, ma'am.
No. So then you say that PV examination was not indicated.
Yes, ma'am.
So then what is your clinical impression now? Just based on the history and examination.
Ma'am, this is a 35 years old female, Gravida 3 para 2 plus 0 live 2. Today she, at the time of examination, she was 35 weeks, 6 days pregnancy with gestational diabetes mellitus on medical nutritional therapy with moderate anemia.
So again, at the same, when you say the diagnosis, you must say whether this gestational diabetes is controlled or not.
This is a controlled, well-controlled gestational diabetes mellitus on medical nutritional therapy.
Right. Okay. Then now, what are the investigations which you have done for her?
Ma'am, once we admitted the patient, we got a routine investigations done. She was a case of moderate anemia. We got the hemoglobin done, and it was 9.4. The iron tablets were advised, and apart from other routine investigations, we got a blood sugar fasting PP done, which was 87.
The patient is 36 weeks, 4 days, and she is having hemoglobin of 9.4. What will you give? Oral iron, or would you like to give something more?
Ma'am, I would like to give IV iron to this patient, but She was planned for giving IV iron, but she took discharge earlier only.
So that is another thing, whether the patient, but what would be recommended?
Now, it would be recommended that we give her IV iron now, since she is very close to her term.
Why do you do that? If the patient is able to tolerate oral iron, can you not give oral iron at 36 weeks? See, your patient was anemic right from the beginning, isn't it? So how did you manage her anemia in her pregnancy? Sorry if I missed it.
Ma'am, during the pregnancy also the patient was advised admission multiple times. She refused every time. She was
What did you do with anemia?
She was advised iron, IV iron also, ma'am. She was advised to get an IV iron administered on daycare basis, but she refused that also. So she was kept on iron tablets and high protein diet on OPD basis and was under follow-up, close follow-up.
So that means only on oral iron, her hemoglobin has improved from 6 to 9.4.
Yes, ma'am.
So that means she is showing a good response to oral iron.
Yes, ma'am.
So maybe, and how much oral iron were you giving? Twice daily or thrice daily?
Ma'am, iron BD was being given.
Iron BD was being given. So that is fine. So if she was responding, maybe then you can continue the same.
Yes, ma'am.
Right. Then, so this patient also has bile acid is raised 15 micromole.
Yes, ma'am. Fasting bile acid was raised. She was initially she was complaining of itching. She was referred to dermatology department for that and was diagnosed with fungal infection. Along with that, her this LFT was deranged, enzymes were deranged, and she was diagnosed with cholestasis as well.
So you did not mention that in the diagnosis.
And she's a case of hypothyroidism also. You have not repeated your
with hypothyroidism, with cholestasis, with moderate. These two things also, they kind of govern your management.
Now, if gestational, since this patient has been complicated with cholestasis, we would like to terminate her at 37 weeks. Otherwise, if a patient
No, but are all cholestasis recommended for termination at 37 weeks? What is the recommendation for termination at cholestasis? प्लीज म्यूट कर लीजिए बाकी लोग. हाँ, कोलेस्टेसिस में बताओ पूजा, क्या रिकमेंडेशन है?
पूजा अनम्यूट करो.
Ma'am, are you audible?
Yes, now you're audible.
हाँ बोलोगे पूजा.
Ma'am, at 37 weeks of gestation, we terminate cholestasis.
Even if it is 15 micromole, 15 micromole is mild, no?
Yes, ma'am.
डायग्नोज बल्कि कितने पे करते हैं आप? तो आरसीओजी की नई गाइडलाइन आ गई है ना, क्या है?
More than 10, if the bile acid is more than 10, it is considered significant and a diagnosis of cholestasis is made.
Now they recommend diagnosis beyond 19 micromoles. and 19 to 39 is mild, 40 to 99 is moderate, and 100 and more is severe. And in mild cases, they allow you to continue till term. In moderate cases, they say for delivery at 38 to 39 weeks. And in severe cases, they say for delivery at 35 to 36 weeks. तो ये 37 weeks वाला तो concept अब खत्म हो गया है.
Okay, so
तो अब फिर से rethink करो.
So as we can see that this patient had 4 ultrasounds so far. Normally in a patient who is diabetic, how many ultrasounds do you recommend?
Ma'am, first NTNB is recommended. Second TIFA, if it is diagnosed before 18 weeks, then TIFA is recommended.
Otherwise, you don't recommend TIFA?
We recommend TIFA in all pregnancies now.
Okay.
It is recommended to get in all pregnancies.
Then?
Ma'am,
28 to 30 weeks.
Next, 28 to 30 weeks scan is recommended, and according to MOHFW, repeat scan is advised at 34 to 36 weeks to estimate the fetal weight.
And polyhydramnios.
Polyhydramnios in a case of GDM.
So just estimated fetal weight is important, or do you look at the individual biometry parameters also of fetus? So just let
Which
everybody know
parameter
that.
is important?
Sorry, ma'am. Sorry.
Do you just look at estimated fetal weight, or you look at the individual biometric parameters like BPD, head circumference, abdominal circumference, femur length?
Ma'am, individual fetal parameters are also important.
So which one would you stress on more in patients who are
abdominal circumference, ma'am? In gestational diabetes mellitus, abdominal circumference is usually more than normal patients. So AC, abdominal circumference, is important.
So when you say more than normal patients, you actually talk in terms of centiles. So that means more than 90th centile, more than 50th centile. Okay. So whenever you write the parameters like how you have written right now, it is a good idea to write the centiles also at the same time.
Yes, ma'am.
So when you read an ultrasound report, also read what centile has been mentioned.
Yes, ma'am.
Okay. So then at 34, 36 weeks, you look at what is the estimated fetal weight, and you look at the abdominal circumference, whether it is more than 90th centile or not. And if it is more than 90th centile, then you assume that this could be a case of macrosomia. And then you look at estimated fetal weight also, where you want to see whether the fetal weight is more than 95th centile. That means it is a large for gestation age baby. So why are you worried? Why do you want to know all this?
Because at the time of delivery, the patient might have the fetus might have shoulder dystocia, because in gestational diabetes mellitus, because of the continuing hyperglycemia of the mother, there is increased fat deposition in the shoulders and the abdomen.
Right. And moreover, as per the Western countries' recommendations, you can also decide on the mode of delivery based on the fetal weight.
Yes,
If the fetal weight is more than 4 kg, even in our setup, we usually do not allow the patient to deliver vaginally.
Yes,
We plan for an elective cesarean section.
yes,
So this patient had a fetal weight of 2.4 kg
yes,
at 36 weeks.
At 34 plus 6 days.
At 34 weeks, 6 days. So what is the centile of this? It is not mentioned, but it would be within the normal centile.
It's in the normal limits.
So that means you can continue the pregnancy, right? It is not showing any features of FGR. Can you have FGR in the presence of diabetes? Is it possible?
Yes, ma'am, we can have FGR in gestational diabetes. Gestational diabetes is usually more commonly associated with preeclampsia, and
any other reason why in gestational diabetes you can have FGR?
ma'am, because of the associated, although it is less likely, but it can lead to vasculopathy, and
sometimes you can have associated vasculopathies, right?
Yes, ma'am.
Okay, and preeclampsia you can have FGR. Okay, go ahead. हो गया? Is that your last slide?
Yes, ma'am.
Okay, so now what do you plan for her? Now she's 36 weeks with cholestasis, with gestational diabetes, with moderate anemia, with hypothyroidism.
Ma'am, now since she is a case of, we have four risk factors: hypothyroidism, gestational diabetes, cholestasis, and moderate anemia. Since she is a case of mild cholestasis, the pregnancy can continue up to 40 weeks. She is a gestational diabetes mellitus case, which is well controlled. So, according to MOHFW, we should terminate her at after 39 weeks, 39 weeks to 39 plus 6 days. And hypothyroidism is not associated.
So, like when you said that now she has mild cholestasis, you had a report of October which said that there is mild cholestasis. No, you need to follow her up with bile acids. How would you know that you cannot label a patient just on the basis of one bile acid that the level will remain the same? It might increase or decrease also.
Yes, ma'am.
So you must say that I would like to monitor her cholestasis, whether she's showing features of severity, and you will continue to monitor her blood sugar profile. Any other method of fetal surveillance? Would you like to admit her or do it on OPD basis?
Ma'am, first method of fetal surveillance is daily fetal movement count, which we advise the patient on OPD basis to count the fetal movements 3 times a day after meals, to lie down for 1 hour on the left lateral position and count for the fetal movements during 1 hour.
Total 10
And
10 fetal movements.
total 10 fetal movements should be there. At every visit, we auscultate the fetal heart sound, and we look for fetal growth on clinical parameters like fundal height and maternal weight gain. And serial USG is also done to see the fetal weight gain and other parameters like polyhydramnios.
Any other method of doing fetal surveillance on OPD basis?
Ma'am, in our setup, we do a non-stress test in term patients. We get an NST non-stress test done for term patients, which is also a
How
method.
frequently would you like to do for her?
Ma'am, a weekly NST. Since she is in 3rd trimester, we are calling her every week with reports of fasting PP. So at every visit, we can get an NST done.
Okay. Would you like to add something with the NST for fetal surveillance?
Biophysical profile.
So biophysical profile, and is there any shortcut also of biophysical profile?
Ma'am, AFI and NST.
What is that called?
Modified biophysical profile.
Yeah, so say that we would like to do modified biophysical profile and NST and AFI every week.
Yes, ma'am.
Okay, and then you plan to, if everything remains controlled, you plan to deliver her by 39
weeks.
Okay. So you have also done one HbA1c in this case as 5.2%. So do you like to follow up a patient of diabetes with HbA1c? What is the role of HbA1c in monitoring diabetic women?
3 months.
And how reliable is the HbA1c in this case? Is there anything which affects reliability in this particular case?
Since she is a case of GDM, we got one value of HbA1c done to see the glycemic control over past 3 months, which came out to be 5.2%. Since it is less than 6.5, the risk of congenital anomaly in the fetus is equivalent to a non-diabetic mother.
See, when you talk of congenital anomalies and HbA1c relation, that is in the 1st trimester. Right, but 10th September, the patient would have been somewhere in the mid trimester, no? Or late 2nd trimester maybe. So then you do not correlate HbA1c with congenital anomalies, but you correlate HbA1c with macrosomias. But ma'am asked something else. Is it reliable in pregnancy, HbA1c? No idea.
And does the hemoglobin of the patient affect the HbA1c?
Yes, ma'am. If a patient is if a patient is anemic, the hemoglobin levels are low. So HbA1c values will also be low, even if the patient has deranged blood sugar.
HbA1c levels will be falsely high for that hemoglobin because the glycylation which happens with glucose is even more stronger and it is even more. But it will not be you cannot predict the diabetes control with that HbA1c when the woman is anemic. It may be falsely high for that hemoglobin, but again, because this woman is already anemic, so it will not be representative at all. I think that is all, ma'am. We can also discuss about the mode of delivery.
So how would you like to deliver her?
Ma'am, since there is no obstetric indication for a cesarean section, we would like to plan her for a vaginal delivery after taking proper consent at 39 weeks to 39 plus 6 days. Had it been that the estimated fetal weight was more than 90th percentile, that is more than 4 kgs, we would have planned her for an elective cesarean section. During the labor, we will monitor her for the blood sugar levels and try for a vaginal delivery.
Okay.
So when would you like to induce her? Would you like to allow her to wait, or would you like to induce her at any time?
Ma'am, at 39, after 39 weeks, we can do a sweep stretch, and then if the patient doesn't go in labor, we can induce her with a preferred method like ICF.
When? She has had 2 previous vaginal deliveries. At what gestation did she have them?
At 9 complete months, that's all. That's all she remembers. She said that she delivered both of them at 9 complete months.
Was she a booked patient in those cases?
Yes, ma'am.
Did she know her expected date of delivery, and was it before that, after that? Kya tha?
Ma'am, the patient was booked at QMH in both of our pregnancies, and
so she must be knowing her expected date of delivery and whether she was and she had spontaneous onset of labor or not.
in both
Or
of
was
the
she
pregnancies,
induced in those?
ma'am, she had spontaneous onset of labor in both of her pregnancies.
Okay, one more thing, ma'am, I want to ask that sometimes when you, these diabetic women, people get 24-hour urine protein, fundus examination. I think in your patient also you got that done, isn't it?
Yes,
So I want to know, is it recommended in all the women who have diabetes that you must do 24-hour urine protein and fundus examination?
What is the rationale, and in which cases is it recommended?
The rationale is to look for the end organ damage, end organ damage, like if there will be fundus changes in case of retinopathy, and there will be change if the proteinuria, if renal damage will be there. Or
Do you do in all patients who have diabetes, gestational diabetes mellitus?
it should be done in patients with uncontrolled blood sugar. Those who are having controlled blood sugar are less likely to have any end organ damage.
So end organ damage does not happen in a month or two, no?
Yes, ma'am.
So that means the women who are type 1 or type 2 diabetic, there you must do end organ damage evaluation in the first trimester if she has not come for preconceptional counseling. Otherwise, you must do it in the preconceptional period. The women who are detected to have gestational diabetes, especially after 20 weeks, are very, very less likely to have end organ. So there it is not recommended that you do 24-hour urine protein or fundus examination.
Amita, you would like to add something?
No, ma'am. It's fine. I just talk about the TSH level. At that time, it was 4.03, but it was not repeated after that.
बताओ, repeat हुआ था नहीं हुआ था?
What should the
And
normal
होना
level of
चाहिए था नहीं होना चाहिए था कितने टाइम बाद रिपीट होना चाहिए था अगर हुआ तो
After 3 months, it should have been repeated. 6 weeks. Sorry, after 6 weeks, it should have been repeated, but it was not done in this patient.
it was not repeated after that.
Yes, ma'am.
Why? As it is with advancement of pregnancy, कोई change आता है TSH levels में?
Ma'am, serum TSH.
what should be your target in first, second, third trimester? What value should be there?
433. Ma'am,
First trimester में 2.5.
Actually मैडम
TSH
ये
levels
केस
के क्या
डायबिटीज
cutoffs
पे था ना,
होते
तो
हैं?
पूरा फोकस डायबिटीज पे था.
TSH लेवल के क्या कट ऑफ होते हैं फर्स्ट ट्राइमेस्टर, सेकंड और थर्ड ट्राइमेस्टर?
in the first trimester, it is 2.5.
2.5 in second trimester, 3, and in third trimester 3.5.
थर्ड ट्राइमेस्टर?
3, sorry.
Yeah, so it remains 3 in second and third trimester. So you titrate your thyroxine dose with the help of TSH levels every month till they are controlled, and after they are controlled, then you do it once in each trimester. So maybe
And
this
कोई
was
lower
done-
limit भी
got
होती है
mentioned in the-
TSH levels की lower limit कि बस upper limit देखी जाती है?
0.3.
Lower limit is also seen, ma'am. It is 0.3, ma'am. If it is less than that, then patient might have hyperthyroidism.
So hyper. So again, it is different in all the 3 trimesters. है ना?
Yes,
And
ma'am.
you have to titrate your dose. अगर excessive dose आप दे रहे हैं, then it may lead to hyperthyroidism,
Yes, ma'am.
iatrogenic. तो कुछ याद है कि क्या है? लोअर लिमिट क्या है? फर्स्ट ट्राइमेस्टर में क्या है, सेकंड में क्या है, थर्ड में क्या है? In first trimester, it is 0.1. In second, it is 0.2. And in third, it is 0.3. So it's very easy to remember. So anything else, or should we move on to the talk?
Yes, ma'am. I think they are quite exhausted.
Shoulder dystocia पूछता है?
Shoulder dystocia. Pooja and Munam, have you seen a case of shoulder dystocia recently? Or maybe so far?
In your 3 years.
Just tell us one quick thing you will do if you encounter a case of shoulder dystocia.
हाँ.
Suprapubic pressure has to be applied.
Suprapubic pressure or?
And
Quickly क्या करते हैं एकदम reflexly अगर किसी patient को shoulder dystocia हो रहा होता है?
Flexing the thighs of the patient and suprapubic pressure.
Yeah, which is called as Macrobids maneuver.
Macrobids maneuver.
है ना? और suprapubic pressure का क्या रोल होता है? कैसे देना होता है? Why are we giving suprapubic pressure?
Ma'am,
To cause the hunching of the shoulders.
yes,
So
yes,
we have to give from behind the anterior shoulder. ठीक है? So that we reduce the base acromial diameter.
yes, ma'am.
So anything else, Amita, you would like to add? So thank you, Amita and Smriti. And thank you, Pooja and Mona. You need to read up more, but you have made a good effort. So now we move on to the talk. Because we did have the talk, maybe you would have got more ideas before for your case. So,
Ma'am,
Vijeta, please take over. Huh.
Are my slides visible?
Yeah, they are visible.
Ma'am, they are visible, ma'am.
So again,
Just make them full screen.
yes, ma'am. So I sincere thanks to Dr. S.P. Jaiswal ma'am and Dr. Anju ma'am for giving me this opportunity to connect with golf again. And I'm so very apologetic I had the entire paraphernalia helping me out, but still I was not able to do it. I don't know, something went wrong. So without wasting any more time, I think we just had a case discussion. Though I'm not going to talk about how big a public health problem diabetes is, because the focus today would
Ma'am,
be
please make it
management
full
and
screen,
monitoring
ma'am.
of these diabetic pregnancies. But we all know that we are all very closely inching to be the diabetic.
Smriti, hello Smriti.
Yes, ma'am.
ये full screen नहीं हो पा रहा क्या बेटा?
मैम हो गया full screen, मेरी तरफ से तो है मैम.
अच्छा, वो हम लोग की स्क्रीन पे नहीं आ रहा ना, इसीलिए. चलो कोई बात नहीं, कंटिन्यू कर लो इसी से.
Okay, so we know that it is a huge problem, and that is why we continue to have these programs on diabetes. And because 14th November is a World Diabetes Day, so it was very aptly chosen to be the topic to be discussed this
Smriti, sorry to interrupt you. Amrita called from Allahabad. Your slides are not visible there. So एक बार reshare कर लो sir.
अच्छा मैम. Ma'am, are they visible now? Ma'am, are they visible now?
Ma'am, हम लोगों को तो visible है ma'am.
It is visible to us.
Can I continue then?
I think Smriti continue कर लो. वो पूरी full screen नहीं आ रहा है, but still it is visible.
मैम अगर ऐसा है तो अंजू मैम के पास भी मेरी स्लाइड्स हैं. We can share from that end.
नहीं कोई बात नहीं, is visible. Continue कर. बेकार में time waste हो रहा है. ठीक है?
So basically, so I have basically made this talk based on the recent recommendations of Government of India guidelines of 2018, and we had a management of diabetes in pregnancy, a very nice article published in January 2022 in Diabetes Care and Up to Date. So when we talk about management and monitoring of diabetes, we're talking about two aspects basically. Number one is blood sugar control, and number two is obstetrics management. So when we talk of blood sugar control, we talk about how we can control blood sugars and how often we must control blood sugars. I think Mona's screen is visible now. Is it, Mona? Hello, ma'am, can you hear me?
We can hear you and we can see your slides full screen now.
Okay. All right. So we were moving on to the management of diabetes. The next one, Mona, I think you're controlling the slides, isn't it? Mona, are you are controlling the slides now?
Mona, are you running the slides? Mona, unmute करो अपने को.
Yes, ma'am. Ma'am, I'm controlling from here, ma'am, and it is visible full screen also, ma'am, now.
All right. So I just keep saying next, okay, Mona, then you can move the slide.
Yes, ma'am. Okay, ma'am.
So please move the next slide. So we talked about how big public health problem it is. Next slide. This is the article which I was telling you. It is a very fantastic article and it is available online. Management of Diabetes in Pregnancy, Standards of Care, published in January 2022. Next, please. And of course, the Government of India guidelines and Up to Date were the main source of this presentation. Next, please. So when we talk about diabetes management, we talk about two important aspects, which is glycemic control and obstetrics management. For our postgraduates, we know that glycemic control means the medical nutrition therapy, the exercise, certain women where it is not controlled. And we know that 95% of the women are controlled just by these two, medical nutrition therapy and exercises. The rest of the 5% we have pharmacological management also. Then we also need to know how often we need to do the glycemic monitoring. We also need to know then obstetrics management, which includes how to do fetal surveillance, how often to do fetal surveillance, when and how to deliver, what are the peripartum challenges, and what should be the postpartum follow-up in these women. Next, please. When we say that a woman should take a limited amount of calories, our goals are mainly that they should be adequate calories to promote health, because we know the recent papers which are coming, especially in the Asian population, are showing that if we restrict too much calories in order to control the blood sugars, we're actually delivering small for gestational age babies. So we need to give them adequate calories, achieve the glycemic goals, and also promote weight gain. Do not try to restrict weight gain too much, because otherwise we will end up with more metabolic complications for both mother as well as the neonate. Next, please. We all talk about calories, we talk about food, but there are certain things which any postgraduate should know when they are talking about management of diabetes, which is the main components of the food, carbohydrates. We know that large amount of carbohydrate, they should be avoided at any cost. There are certain complex carbohydrates where the breakdown of the sugars is much slower, so they should be preferred as compared to simple carbohydrates. And simple carbohydrates are like sugars. They're like maida, they're like refined sugars. However, the complex one would be the where you find the whole grains, they have complex carbohydrates, etc. And as we were talking in the case also, we should never allow the patient to take 3 meals which are heavy. Rather, all her entire caloric intake should be split up into 3 major meals and 3 minor meals. Saturated fat like ghee also should be less than 10% of the calories. We must definitely do caloric restriction. We will come to that, but also make sure that the woman is not fasting, because fasting women will lead to increased ketone levels in both blood as well as urine, and they will impact the fetal growth. Next, please. Similarly, proteins we definitely need for the fetal growth, 2 to 3 servings in the form of eggs, meat, or if the woman is a vegetarian, then of course, dals and paneer, soya. These things should be used to increase the protein, and at least 2 servings should be there for a woman. That is why we insist that they have dal at least 2 times in a day. Or if she is not having dal, then at least sprouts once should be added. Then of course, fiber, which comes in the fruits and vegetables. Next, please. So we talked about the calorie requirement. I am sure that this looks a very complicated equation, so we need not memorize it. It's a good idea now to click a picture of it and keep it with us anytime a woman comes, so then we can easily go on to this. So what we need to see here is that this BMR calculation is what is a resting metabolic rate. And this is based upon the age of the women. So if it is less than 30, the equation, the formula is the first one. And if the age is more than 30, then the BMR changes. And that is when we need to see the second equation. And this is the physical activity level. Naturally, as the woman is increasing her physical activity, the conversion factors will change. And these are the conversion factors. Again, I repeat, do not try to memorize it. Just keep a screenshot or photo of it handy with you whenever you need to advise it to the women. And now 350 calories on top of this should be added for every pregnant woman who is in the 2nd and 3rd trimester in a singleton pregnancy. If a woman is a multiple pregnancy, twin gestation, then we need to add at least 450 calories to the diet intake. Next, please. So this is just an example. We don't need to discuss this because in our case presentation also we saw how the calorie count was done. Next, please. So these are the next few slides. Again, as I insist that you can click a picture of it and keep it in your phone so that you have an idea what kind of a meal plan you give to a woman when you have a specific calorie requirement. For example, this is for 1800. The postgraduates can click a picture and again keep it with their phone. Next slide. That is 2000 calories. Next is 2200 calories. And after that, we have 2400 calories. Now, the main thing about these, which is important to remember, is that again, the meals are spaced. There are 3 major meals and there are 3 minor meals. Depending upon the caloric requirement, the amount of calories, which can be, for example, the number of chapatis, for example, the other substitutes which are taken, number of fruits, number of times the woman is taking proteins or carbohydrates, all these things can be that way regulated. And what is also very important is do not try to impose a diet plan on the women. Always ask her what she has been eating all these days, all these months, and try to modify that diet only. Because suppose if a woman is used to eating a sandwich in the morning, and if you ask her to have a chapati, she will obviously not be able to eat that. And if she is used to eating chapatis in the morning, then you ask her to have idlis, that will not be practical. So try and find out what she is used to eating and modify the diet plan as per the calorie requirement according to what she is eating. Next, please. Another very important concept which we need to remember is the glycemic index of the food. Remember, you need to give certain amount of carbohydrates. Give foods which have low GI and not high GI. The low GI foods, next please. Next slide. So the low GI food are like legumes and lentils, which are the whole grains, जो साबुत मूंग होती हैं, राजमास होते हैं, peas, green grams, इन सब में fiber होता है and they are low GI foods. The medium GI foods are like fruits like apples, pears, guavas, and high GI foods which have high glycemic index means as soon as you eat that food, the sugar levels will rise very rapidly. And they are like rice, wheat, white bread, potato, carrot, chocolates and sweets. Then of course, syrupy foods like you have those, certain people like to eat some kind of juices. They are syrupy foods. So they have high GI. So remember, give her good carbohydrates, but give her low GI carbohydrates so that the amount of sugar which is released is slow and steady and it maintains that amount in her bloodstream. Next, please. Now, this is again a very important concept for postgraduates that whenever you tell a woman, tell her that half of her table should be filled with vegetables, and vegetables can be either cooked or raw because the calorie amount in these salads and cooked vegetables is much lesser. And then 1/4 should be cereals, which can be rice or chapatis, and 1/4 should be proteins, which is like dals or sprouts or paneer, etc. 1 serving of fruit and 1 serving of dairy product. So these are because our women who come from a rural background would probably not be able to understand if you say you eat this much and you eat that much. However, if you tell them that they can fill their half of their plate with the help of vegetables and the rest 1/4 with the roti and the 1/4 with the dal, that way they will be able to understand better. Next, please. So this is again a very important concept, signal system, where the same food, if the way it is cooked, you can actually say whether it is a healthy or an unhealthy food. For example, if you take rice, now commonly the rice which is available in the market is white rice. That white rice comes in the yellow signal. However, if you add oil to it and if you add other spices and especially oil, then you make a biryani out of it, that becomes red. Steamed brown rice may be available and that is of course a healthier variant of it. Similarly, white bread, which is so available in the market, is yellow. However, maida like cakes and cookies and croissants, they have a red signal, so they should be eaten in sparse amount. Whole grain bread, of course, a good option. So similarly, all these things, for example, even meat, if you stir fry it with little oil, it is yellow signal. However, if you deep fry it, then it becomes red. If you steam or grill the same meat like fish, etc., then it becomes a healthy variant. Next, please. Mona, next slide. So this was about the diet. Now, when we talk of exercises, we talk about 30-minute moderate intensity. We talk about so many other things and upper body exercises. Next, please. But we need to remember a very, very simple dictum. A simple dictum can be that you should never force anything on the patient. Whatever, if the woman who is not used to doing exercises, that even if she takes 100 steps after every meal, it is more than enough. Or if she just does upper body low resistance exercises for 10 minutes after every meal is also enough. However, if the woman was used to doing a lot of exercises, then maybe in those women, she can continue with the same moderate intensity exercises even in her pregnancy. Mona, can you move the next slide? Yeah, so these are the two simple dictums, 100 steps after every meal or 10-minute exercises after every meal, because most of the pregnant women are either hesitant or they have never exercised in their lives. And for them, doing anything new would be a little scary. Next, please. These are the simple exercises which a woman can do, the upper body exercises, which are wall squats, wall push-ups, weight trainings for upper limbs. The main idea is that her torso and her lower limbs are not under any kind of a strain. Next, please. So this is about the weight gain. This is a very, again, important thing for the diabetic women. For this, we need to remember that the women who come under the normal BMI category, they can have a weight gain up to 16 kgs. The women who are underweight, around 18 kgs. The women who are overweight, around 11.5 kgs, they can have a weight gain. And the obese women should not have weight gain more than 8 to 9 kgs. So it is very important that you monitor the weight gain of the women. Next, please. Now we'll come to how to monitor the blood sugars. So basically, the ACOG and the American Diabetes Association and the Government of India, everybody is in sync with this. And everybody says that the fasting blood sugar should be kept less than 95 and 2-hour postprandial should be kept less than 120 milligram per deciliter. Now we were talking about HbA1c. HbA1c levels in pregnancy are definitely not predictive. Number one, there is an increased RBC turnover. And so they do not represent what the blood sugars have been, and they cannot actually predict macrosomia. Even in the first trimester, HbA1c less than 6% is a good thing. But later gestation, maybe this HbA1c of 6% cannot be achieved, or it's very difficult to achieve. So sometimes it can be relaxed to less than 7% also. Then you have another concept, which is CGM, which is continuous glucose monitoring. Now, continuous glucose monitoring has not yet been studied in the women who have gestational diabetes mellitus, but in type 1 and type 2 diabetes, they can be really helpful. We will come to that. Next slide, please. Now, the pregnant women who has diabetes, now we have seen that we must give them medical nutritional therapy and exercise. See her blood sugar straight after 2 weeks. Do not be in a hurry. Do not admit them. If their blood sugars are just like mildly raised and they come under the category where you need to give her on medical nutritional therapy and give her exercises that is more than 140 milligram per deciliter, just give her 2 weeks of diet and just give her 2 weeks of exercises. And then after 2 weeks, just ask her to come back and do a post-lunch blood sugar, 2 hours post-lunch. If that value is less than 120, that means you're happy, and you continue with the same medical nutritional therapy and exercises. The frequency of monitoring can change. Most of the times it is once in 2 weeks, even after 28 weeks sometimes when the blood sugars are well controlled. Then also we continue to monitor the blood sugars once in 2 weeks only. However, if you have any kind of a doubt about her compliance or about her blood sugars, then maybe you can repeat it every week. Now, if the blood sugar, that is 2 hours post-lunch, which has been done after 2 weeks, is more than 120 or equal to 120, that is when you need to start her on pharmacological management. Next, please. And pharmacological management can be 3 things. They can be insulin, they can be glyburide, or they can be metformin. All 3 of them are effective therapies. They can be initiated as first-line management, but now as per the guidelines, ACOG and American Diabetes Association, they usually recommend that insulin should be the first line management. But Government of India has also said that metformin can be given, but after 20 weeks. So metformin is a better choice than glyburide. The dose of metformin which you start, the previous one, please. So the dose of metformin which you start is 500 milligram BD, and then you can slowly titrate it as per the blood sugars, and maximum dose is 1 gram BD. The dose of glyburide, if it is being given and people have experience with it, can also be given in a starting dose of 2.5 milligram per day, and then you can increase it to 2.5 milligram BD, and then 5 milligram BD, and then 10 milligram BD, because the maximum dose is 20 milligram per day. Next, please. Now, when to start insulin? Now, most of the people, especially the gynecologists, they prefer to give insulin because they have been using insulin for very long time. But otherwise, metformin is also a very good alternative, especially after 20 weeks, as per the Government of India. Now, when you think that this woman is probably not going to respond to your metformin or glyburide, you can start insulin as the first line. And what are those conditions? If suppose the fasting plasma glucose is more than 110 milligram per deciliter, then you know that you are actually, the sugars are high, and then maybe you need to control them fast. If the woman who comes to you maybe by 30 weeks or 32 weeks and her weight gain is already more than 12 kgs, then it is a good idea to start insulin first thing. If you have diagnosed diabetes less than 20 weeks, because Government of India does not recommend to start metformin before 20 weeks, so you should start on insulin. Or sometimes when you diagnose and you think that pharmacological intervention is needed after 30 weeks, then again insulin is a better option, because oral anti-diabetics, they take a longer while and they can probably have a lesser efficacy as compared to insulin. Next, please. Now, when you talk about, so this is again a chart to say that when you have started her on insulin, then you titrate her blood sugars every third day. And our targets are the same, which were for the diet intervention, which is fasting blood sugar less than 95 and 2-hour postprandial less than 120. Next, please. So now when we come to what insulin and how much insulin, as per this Government of India recommendations, it is a very, very simple strategy. The Government of India recommends that we give a mixed start insulin, which is 30 to 70, 30 is to 70. In this 30 is the regular and 70 is the NPH. This is given 30 minutes before breakfast once in a day. And usually when the blood sugars are in the range, here we're talking about postprandials. So 2-hour postprandial 120 to 160 start with 4 units. 160 to 200 start with 6 units. If it is more than 200 postprandial, then you start with 8 units. Then again, you titrate the blood sugars. Now, if the fasting blood sugars are rising, as you can see here, then maybe you need to add the insulin before dinner also. But if the fasting is controlled and only PPs are rising, then you need to just keep increasing the morning insulins, which is before breakfast. Next, please. Now, as postgraduates, you must know that the Government of India recommends insulin mixed start, but there are other insulin analogs also which are available in the market. So in that, Lispro and Aspart are very commonly used, especially if you see around in the private, among the private practitioners, endocrinologists especially, they like to start Lispro and Aspart insulin. So we need to know that this Lispro and Aspart insulins, they are rapidly acting insulins. They act within 10 to 20 minutes. So like the mixed start insulin was given half an hour before meals. These rapidly acting insulins can be given just before the meal. The peak of action is usually 30 to 90 minutes. The short actings, which we usually use as regular insulin, that can be given half an hour before the meals, and because it peaks after 2 to 5 hours. Now there is another insulin called as Velocillin. Just for your exam purposes and for your knowledge, you must know that this is the insulin which is used in the insulin pump. And then you have the intermediate acting, which is NPH. This is given usually at the bedtime, and it usually lasts for, the action lasts for around 12 hours. So this is usually given at bedtime. So when you need to give a you're giving separate insulins, so you kind of give rapid acting or short acting before every meal, and NPH is given at bedtime. Next, please. Next, please, Mona. Okay, so there are more insulins beyond that. For that, we have the long-acting insulins. Can we have the next slide? So the long-acting insulins are basically Glargine and Dept. And Glargine insulin has been widely studied. Mona, I think the slides have disappeared. Mona, should I do the slide share?
आपकी तरफ से कर लीजिए, इधर कुछ प्रॉब्लम हो गई है.
Okay, okay. Is it visible?
Yes, ma'am, it's visible.
So yeah, the long-acting insulins, which we usually see are Glargine insulin and Dept insulin. Glargine insulin does not have a peak time. That is a very big advantage of Glargine insulin because it can be given once in 24 hours and it does not have any peak at all. Dept insulin is also a very good long-acting insulin. Then of course we have the mixed start insulins like 70-30 Humulin, which we just talked about, insulin mixed start. So Aspart and Lispro, they have been studied and they are very safe. NPH, of course, has traditionally been used for a long time. Detamir has also been studied, and now there is extensive clinical experience with glargine also. Now, insulin can be given by various methods. You can either give intermittent doses or you can give continuous pump, subcutaneous regime in the form of insulin pumps. Then, of course, you have a hybrid closed loop system. Again, for the knowledge purpose, the postgraduates must know. But this is not used in pregnancy because this usually has a blood sugar target level of 120. And this is much above our recommended fasting goal. In pregnant women, we usually take up to 95. So that is why this hybrid closed loop system cannot be used. Then this is the continuous glucose monitoring. Now, continuous glucose monitoring, when it was used in type 1 diabetes, it was found that it is a very good method. Less chances of macrosomia and less chances of neonatal hypoglycemia. But as I said, that we have not yet studied this continuous glucose monitoring in gestational diabetes, and we have no data about it. So now we come to how to administer. Give it subcutaneously, of course. Where to store? In the fridge. Make sure that the insulin is kept in the door of refrigerator, so the temperature is maintained between 4 to 8. Make sure, tell the patient, clean the site properly, check the expiry, warm the insulin slightly in between the fingers so that before injecting, withdraw the piston and discard the syringe if it is a single-use syringe. These are the sites where the insulin can be used. Even the pregnant women can use it safely on the maternal abdomen. Of course, they must remember that they must keep changing the sites so that there is no lipodystrophy at one particular level. So that was about glycemic control. So we talked about the types of insulin, how insulin can be given and how sugar should be monitored. Now we come to the fetal surveillance. So we know that we discussed this in the case also, that we do an early pregnancy ultrasound to confirm viability, anomaly scans, of course. Fetal echo is also recommended in diabetic women, not in all, especially in those women their first trimester sugars were not controlled, or there is a suspicion of cardiac defect on the TIFA scan. Then we come to fetal surveillance. Ultrasound is done to monitor the fetal growth. We don't have any recommendations on when to start and how frequently. But if the fundal height is more than the period of gestation, there is an excessive maternal weight gain, or the sugar controls are poor, then you start it from 28 weeks onwards. Otherwise, you can even start it at 32 weeks. So monitoring should also be done with the help of once weekly or twice weekly, and biophysical profile or modified biophysical profile can be started early or whenever it is needed, and frequency can be individualized depending upon the complications of a woman. So now we come to when to deliver. Now this chart has been taken from FIGO guideline. And if you see in this chart, you can see that till 38 weeks, you just continue with the pregnancy, the sugars are controlled. Then you see if the sugars are poorly controlled, or if a patient has had a previous obstetric complication or the compliance is poor, then you must deliver her at 38 weeks. If, however, the fetus is growing very large, then of course, again deliver her. If the fetus is less than 4 kg, then you can induce labor. If it is more than 4 kg, then you should offer elective cesarean section. Another way of understanding this is that if you think that A1 diabetes is diabetes which is controlled only on diet. So if it is optimally controlled, then carry on the pregnancy till 39, aram se, and then deliver her after that. However, if the pregnancy is on pharmacological management, which is A2 or A1 with suboptimal control, then you need to see whether the woman is having any concomitant comorbid conditions or not, like hypertension, or whether previous stillbirth, etc. Then if you can deliver between 37 to 39. Otherwise, again, A2 diabetes, that is pharmacological management, you can deliver by 39 weeks. ACOG, in fact, says that you can go even beyond 39 weeks, but we usually like to deliver them by 38 to 39 weeks. So you can also plan 37 weeks onwards, but remember, less than 37 weeks should be done only when you have tried everything and you are still not able to control her blood sugars, because poor blood sugar control after 37 weeks can lead to stillbirths. Now, if steroids are required, like we saw in this case presentation, that the steroids were given, though Steroids should be given only when they're indicated. But if steroids are required, then you increase the insulin requirement for 3 to 5 days if the woman is on insulin already, and do a good glucose monitoring. You can also, if the woman was already on insulin, then you add 5 units subcutaneous before every meal, or you can also give intravenous or pump based insulins and keep a target of 70 to 126 milligram per deciliter. Now, when a woman is in labor, remember to make sure her blood sugars are controlled. They should be between 100 to 126. Withhold the morning dose of insulin and keep the blood sugars. It is mentioned in the Government of India at 70 to 126, but try to keep it between 100 to 126. And again, this is the way how the sugar should be controlled. If the sugars are going high, more than 120, then you start with 4 international units of insulin, regular insulin, in 500 ml of normal saline, and started at 100 ml per hour. If the sugars are more than 140, then increase the amount of insulin in the bottle to 6 units. Give it at the rate of 100 ml per hour. If it is more than 180, then 8 units. Give it at the rate of 100 ml per hour. Newborn care, of course, very important. Make sure that the baby does not have hypoglycemia, because a baby born to a diabetic mother will definitely have high insulin levels and will develop hypoglycemia later on. Also look for the other neonatal complications like bilirubinemia and RDS. Now we come to a very important aspect, how to manage them in the postpartum period. If the woman was already on high doses of insulin, then come back to 1/3 or half of the pre-delivery doses. And once the diet has been resumed, then of course you can slowly get back to the amount of insulin which she was taking before delivery. Frequent glucose monitoring should be done. The women who are diabetic, you stop all the oral anti-diabetic agents, insulins or metformin or glyburide, whatever. Just check her sugars before the discharge. Again, HbA1c does not have a good, it's not a good modality, because there is an increased RBC turnover because of the blood loss. And so it is a good idea to do OGDT only. And the values are, the fasting should, if it is more than 126 and 2 are more than 200, then you know it is diabetes. If, however, it is impaired in the form of 140 to 199, the 2R value, then just advise a lifestyle modification and continue to monitor her sugars at yearly interval. So the postpartum follow-up includes early detection of infections, support the breastfeeding, advise on pregnancy spacing with the help of contraception, retest the blood sugars at 6 weeks, and continue to monitor the blood glucose. All women should be supported in breastfeeding, because breastfeeding will help not only the mother, but definitely the neonate to a large extent, and can prevent the, however, lactation can increase the risk of overnight hypoglycemia. So you should monitor the sugars and insulin dosage accordingly. Contraception options are the same for the women, and recommendations are same. Long-acting reversible like IUCD, etc. are the best for these women. So this is just to sum up. I hope we have been able to revise the diabetes, that you start on medical nutrition therapy and exercise. Do only 2-hour post-meal blood sugars after 2 weeks. If it is less than 120, it is good. If it is more than 120s, you can start on insulin or metformin or glyburide. Then monitor her blood sugars. If insulin is required, remember to start in low dose. You can give mixed start in the form of 30-70, or you can also give regular insulin 3 times before meals and NPH at bedtime. So on the occasion of World Diabetes Day, let us all be very, very careful and do our own bit to control the blood sugars in the pregnant women. Thank you.
Thank you, ma'am. Thank you so much.
Thank you, Smriti. Thank you so much for your excellent talk. You have covered all aspects and you explained everything very nicely.
Thank you. I'm so sorry for the glitch which happened in the afternoon.
No, it was not in your hand. No, it was not in your hand. But your presentation was wonderful. बहुत अच्छा रहा है. I feel my resident would be very happy. From beginning to, they have even the recent guideline also. So you have explained very well. Any question, any query? I think कोई और भी लोग जुड़े हैं. हाँ जी अंजू, बोलो.
हाँ मैम, बहुत अच्छा प्रेजेंटेशन था.
Thank you, ma'am.
एंड बहुत लोग जुड़े हैं. अमृता एंड इलाहाबाद की टीम पूरी जुड़ी हुई है हम लोग की.
नहीं, वही लग रहा है कि बहुत सारे लोग आज जुड़े हुए दिख रहे हैं. नाम तो बहुत आ रहे हैं, लेकिन डेफिनेटली योर प्रेजेंटेशन डेफिनेटली इज वंडरफुल। बहुत अच्छा रहा, तुमने बहुत अच्छे से कवर किया हुआ है। थैंक यू सो मच।
Thank you, ma'am.
Any
Thank
query,
you,
any
Smriti
question
ma'am,
from
for such an
anywhere?
excellent talk. Now I would like to invite Dr. Mona Asnani ma'am. Ma'am is additional professor in the Department of Obst and Gynaecology. Ma'am, hello.
First, thank you so much, ma'am.
Concluding
Thank you
remarks.
all. First of all, I would like to extend my gratitude to esteemed HOD Jaswar ma'am and Anju Agarwal ma'am for giving me opportunity to join with this program. And this is a unique program. And special thanks to Uma ma'am and HP Gupta ma'am who spared some time to join in this program. And today's topic is really very, very important because India is becoming the diabetic hub. And I'm sure residents would have learned a lot from this discussion because they have learned from the expert from the subject, Anju ma'am and Smriti ma'am being the part of a national guideline constituting team. Thank you, Smriti ma'am. Your lecture was really, really very wonderful, ma'am. It was very comprehensive. I'm sure residents would have learned a lot. Case discussion was also very interactive and elaborate. Thank you, Dr. Amita Yadav, for accepting the invitation and joining in this program. Thank you all the faculty and all the participants. Thank you all.
Thank you, Mona. Thank you, Anju ma'am again. Thank you, Jaiswal ma'am.
Thank you, Anju ma'am. Thank you, Jaswar ma'am, for making me and give me this opportunity to make this in this good discussion.
Thank you, ma'am. मैम अंजू मैम म्यूटेड हैं आप।
मैं तो बोले जा रही थैंक यू सबको। Thank you everyone. Thank you ma'am. Thank you Spriti, Amita and all our residents who are joined. Thank you so much.
So thank you to all of you. तो अंजू अब हम लोग खत्म कर सकते हैं। We can take
जी
leave.
मैम, जी जी।
Thank you.
ma'am.
Thank you to all of you.
Thank
Thank you so
you.
much.
जिग्नेटिक में बहुत गड़बड़ चल रहा है। अगर मैं